Biomechanical assessment is essential for uncovering problems in the foot, ankle, knee, and pelvis that might lead to pain or injury. Assessment components include static assessment, dynamic assessment, and context specific observations. It involves structural biomechanical evaluation. Evaluation is based on the analysis of running biomechanics. It includes functional activities like walking, running, and sport specific movements, for example, kicking. We start with static assessment. This includes visually inspecting the foot for abnormalities and evaluating posture using the foot posture index. The FPI is a 6-item tool scored from -2 to +2. It gives a quick quantitative assessment of the rear foot, midfoot, and forefoot posture to determine the overall foot type. Next, we assess the range of motion at the first metatarsophalangeal joint using Jack's test. Normally, the big toe dorsiflexes about 50 degrees, tightening the plantar fascia and causing rear foot inversion. Abnormal findings include no rear foot inversion suggests poor plantar fascia integrity leading to inadequate supination. Reduced range of motion indicate a valgus aligned forefoot. Management options include use of orthosis, taping, and corrective exercises to address structural issues. Ankle dorsiflexion is critical for proper gait. Inclinometer is preferred because it's accurate, fast, and practical. We measure dorsiflexion with the knee flexed and extended. Normal ranges are 45 and 40 degrees respectively. Alternatively, you can use a lunge test to compare sides, but keep in mind this won't reveal bilateral gastrocnemius tightness as a cause of restricted dorsiflexion. Tibiofemoral alignment can reveal issues like genu varum or genu valgum. Using an inclinometer ensures accuracy similar to radiographic results. We also assess leg length and pelvic alignment. A difference greater than 1 centimeter is clinically significant. We evaluate both weight bearing and not weight bearing to pinpoint the source, whether it's pelvic asymmetry, structural difference, or foot posture. Functional leg difference is caused by asymmetrical foot posture, for example, pronation on one side, despite anatomically equal leg lengths. Structural leg length difference is indicated by asymmetrical foot posture and confirmed by supine not weight-bearing measurement. Non-weight bearing assessment measures from anterior superior iliac spine to medial malleolus with the femur in neutral rotation. And remember, there is no single best way to assess biomechanics. It all depends on the clinical presentation.